Hello, everyone, and welcome to our module on regulation of blood pressure. So blood pressure is required for the perfusion of tissues. It's the driving force for blood flow through all the organs in our body. And in this video, we're going to talk about the ways that the human body maintains a normal blood pressure to drive blood flow through all the organs. And just a couple of general points before we start. You should be aware that blood pressure varies with sodium and water intake. The more sodium and water we have in the arteries in our body, the higher the blood pressure. And you should also know that our blood pressure is regulated by the nervous system, especially the nerve fibers of the sympathetic nervous system. So the way our body senses blood pressure is via stretch on structures known as baroreceptors, which are found in a number of places in the body. We'll talk about where in just a minute. So when blood pressure goes up, these baroreceptors are stretched, and that sends signals to the brain letting it know that blood pressure has gotten higher. The opposite happens when blood pressure goes down. So these signals go to the nervous system, go to the brain, and the brain responds through the autonomic nervous system by fibers in the sympathetic and parasympathetic pathways, and we'll talk about this in detail in just a minute. There are a couple of different things that the brain can modify to control blood pressure. The first is the heart rate and the degree of left ventricular contractility. The second is the arterial tone. The brain can cause vasoconstriction of arterioles. This increases vascular resistance and raises the blood pressure. The brain can also modify venous tone. When there's more tone, meaning more constriction of veins in the body, that pushes blood out of the venous system into the left ventricle and provides more preload to the left ventricle, and that raises the cardiac output, which can affect the blood pressure. And then finally, in the kidneys, renin can be released when there's low blood pressure, and this drives the retention of sodium and water and also causes more vasoconstriction. And I talk about the entire renin-angiotensin-aldosterone system in detail in the renal section. So the major baroreceptors for sensing blood pressure are found in two places, the aortic arch and the carotid sinus. If you look at this cartoon on the screen, the aortic arch has a number of baroreceptors, and so does the carotid sinus. Both of these baroreceptors signal the brain and allow for quick responses to changes in blood pressure. Basically, these two systems are constantly signaling the brain, and the brain is modifying the autonomic nervous system to keep your blood pressure normal. The other place where blood pressure is sensed is in the kidneys. The kidneys can modify renin release to modify blood pressure up or down, but you should know that this is a much slower process. It requires the release of hormones and the activation of enzymes, whereas this process via the autonomic nervous system is very rapid and within seconds can respond to changes in blood pressure. The baroreceptors in the aortic arch and carotid sinus are a little bit different. The ones that are found in the aortic arch mostly sense elevated blood pressure. They have a very poor ability to sense low blood pressure. In the carotid sinus, however, this is where you find baroreceptors that can modify their signals to the brain over a very wide range of blood pressure. They can sense both low and high blood pressure, and that makes these the most important baroreceptors found in the body because they can sense such a range of pressures and signal the brain about what's going on. Okay, so here's a little cartoon I made on my own, which I'll use to illustrate to you how blood pressure is sensed by the brain and how the brain modifies activity of the autonomic nervous system to keep the blood pressure normal. So the blood pressure is sensed by baroreceptors in the aortic arch, which sends signals via cranial nerve 10, the vagus nerve, to the brain. It's also sensed, as we just discussed, by baroreceptors in the carotid sinus. That structure sends signals to the brain by cranial nerve 9, the glossopharyngeal nerve. So afferent fibers, remember A means for arriving in the brain, afferent nerve fibers take signals from these baroreceptors to the brain to tell the brain what's going on with our blood pressure. The brain then responds through the sympathetic and parasympathetic systems. As I said before, it uses efferent nerve fibers. Efferent means fibers that exit the brain. And through these efferent fibers, it can modify the constriction or dilation of veins and arteries like we discussed. It can also modify signals to the heart to raise or lower the heart rate and contractility. And the structure in the brain that coordinates all this blood pressure control is called the nucleus solitarius, and I discuss this in more detail in videos in the neurology section. So now let's go through a little thought experiment and talk about what would happen if your blood pressure suddenly went up. Well, that would stretch baroreceptors in the aortic arch, and those baroreceptors would send signals to the brain via cranial nerve 10. The higher blood pressure would also be sensed by baroreceptors in the carotid sinus, and it would send signals to the brain via cranial nerve 9. The brain would then respond by the sympathetic and parasympathetic systems. It would tell veins to dilate, because when veins dilate, they pool blood in the venous system, and this lowers the preload to the left ventricle. This will drop the cardiac output, and that will tend to bring the blood pressure down. The brain will also tell the blood vessels in the arterial system, the arterioles, to dilate. This will cause peripheral vasodilation, and that will tend to bring the blood pressure down. In the heart, the brain will tell the heart to slow the heart rate down and decrease contractility, and this is also going to drop the cardiac output, which lowers blood pressure. So through all these mechanisms, the brain is going to modify the physiology of the body to try and bring the blood pressure back down to the normal range when it's high. Now, separate from this whole system, the kidney has its own system for sensing high blood pressure, which I talk about in the renal section. But what the kidneys are going to do in response to high blood pressure is decrease salt and water retention. They're going to try to excrete salt and water, and that's going to bring down the blood pressure. The reverse of everything I described on the last slide happens if the blood pressure suddenly gets low. For example, if a patient has massive hemorrhage. Signals will be sent to the brain, letting the brain know that the blood pressure is low. And then what's going to happen is, first of all, the veins are going to constrict. The sympathetic nervous system will tell veins to constrict. That will push blood from the venous system into the heart, raising the preload and raising the cardiac output, which will bring up the blood pressure. The brain will also tell arterioles to constrict. This will raise the peripheral resistance and raise the blood pressure. And in the heart rate and the left ventricular contractility will go up. So these are all the opposite of what we talked about in the last slide for high blood pressure. And then finally, in the kidneys, low blood pressure stimulates the retention of sodium in water via the renin-angiotensin-aldosterone system. And once again, I discuss all that in the renal section. So there's a couple of quirky manipulations of this system that often come up in board questions. So I'll go through those in the next couple of slides. And the first one is carotid massage. So if you press or massage your carotid sinus, which is found in your neck, you will stretch baroreceptors there, and that will trick the carotid sinus into thinking that there's high blood pressure. And so the body's going to respond by lowering the heart rate, vasodilating blood vessels, causing low blood pressure. And this is a rare cause of syncope. The classic example is someone who is shaving or buttoning a shirt collar. They press on their carotid sinus and then they faint. And the reason they're fainting is because they've triggered this whole system to respond as if the blood pressure's high, and the result is a sudden drop in blood pressure. And the way that the system responds to carotid massage is the same way we talked about before when blood pressure gets low. Basically, veins will dilate, arteries will dilate, heart rate will go down, all the things that lead to low cardiac output, vasodilation, and low blood pressure. Another quirky situation that comes up in this system is if the carotid artery becomes occluded. This will cause ischemia of those baroreceptors in the carotid sinus, and they'll stop sending signals to the brain. And this will trick the brain into thinking that there's low blood pressure. And so the system's going to respond just as we talked about before for low blood pressure. The veins and arteries will constrict and the heart rate will go up, and all these things will tend to increase the blood pressure. And that's what you can see if there's occlusion of the carotid artery. Another manipulation of this system could happen if cranial nerve 9 is severed. For example, during head and neck surgery, this can sometimes happen. So when this occurs, there'll be no signals from the carotid sinus to the brain. And remember what I talked about, the carotid sinus is the most important baroreceptor. So if those signals go away, then the brain is going to think there's low blood pressure, and it's going to respond in all the usual ways to low blood pressure, more heart rate, vasoconstriction, and raising the blood pressure. So you may be wondering what happens if you sever cranial nerve 10, the vagus nerve. That would interrupt the ability of the aortic arch to send signals to the brain. But remember what I said before, the carotid sinus has the most important baroreceptors. So in this situation, the ability of the brain to sense blood pressure actually remains intact. The main problem with severing cranial nerve 10 is that you interrupt all the parasympathetic fibers going to the heart. This is a rarely done surgical procedure called a vagotomy. And so with no parasympathetic fibers going to the heart has unopposed sympathetic cardiac stimulation, and this results in a higher heart rate and also higher contractility. Years and years and years ago, this was done for patients with heart failure to try and make their heart rate and contractility go up. But the bottom line is that the main effect of severing cranial nerve 10 has nothing to do with interrupting the body's ability to detect blood pressure, but it has everything to do with losing the parasympathetic stimulation to the heart. So here's a summary of those quirky situations or techniques that interrupt this system. These make for very good step 1 board questions. So in carotid massage, the brain interprets that as high blood pressure and responds with a decrease in heart rate and blood pressure. In carotid occlusion, the brain interprets that as low blood pressure and responds with a rise in heart rate and blood pressure. If you sever cranial nerve 9, the brain will think there's low blood pressure and respond in the usual way. And finally, the main consequence of severing cranial nerve 10, the vagus nerve, has to do with the heart, and you see the heart rate go up for the reasons we just discussed. Okay, now let's switch gears a little bit and talk about coronary blood flow. So if you look at this graph on the left side of the screen, at the top we have the aortic blood pressure. And as you know, it goes up and down between a low of about 80, that's what the normal diastolic pressure is, to a high of about 120 in normal patients. And it's in this period of systole, when the pressure is rising to its peak, that most organs have their maximal blood flow. The pressure is the highest, and that drives blood flow to its maximal point for most organs. But the coronary arteries are totally different. At the bottom of the screen, it shows the coronary blood flow, and you can see that it reaches its lowest point during systole. This is unique to the heart. Only the heart has low blood flow in systole, and its maximal blood flow actually in diastole. So if you look over here on the left side of the screen, I've showed you systole in blue and diastole in green. And diastole is when the coronary arteries have most of their blood flow. And this has consequences for when patients get tachycardic, because when the heart rate is very rapid, there's less time in diastole, and therefore less flow could occur through the coronary arteries. But luckily, they're able to vasodilate to maintain flow, so that in the setting of tachycardia, those arteries are massively dilated, and that maintains flow, even though the time in diastole is relatively short. Let's talk about regional blood flow to the areas of the heart. So the epicardium is the outer surface of the heart. It's this surface shown here in the drawing, and that's where you find the coronary arteries that are delivering blood and oxygen to the heart. In contrast, the endocardium is the innermost layer of the heart. It's the layer that interfaces with blood in the chambers. Now, this endocardium can get oxygen from the blood inside the chambers of the heart, and the epicardium has arteries out here receiving blood and oxygen. But the subendocardium, this layer right here, has to get its oxygen from the coronary arteries, which are very far away. So it turns out that the subendocardium receives the smallest amount of blood flow. That's because it's furthest away from the coronary arteries. And for that reason, the subendocardium is the most vulnerable to ischemia. If there's a decrease in blood flow, it's the area most likely to not get enough oxygen. So besides the heart, some of the other organs in the body have special features to their blood flow. The lungs, as you may know, receives 100% of the cardiac output. The heart and the lungs are the only two organs that get all of the cardiac output. The other organs just get a portion of the cardiac output. The liver gets the largest portion of the entire systemic blood flow. However, the kidneys gets the highest portion by weight. And then finally, we talked about the heart and how the coronary arteries supply blood to the different areas. But some other things to know about the heart are that it has the largest change in oxygenation going from the arteries to the veins. Basically, the heart extracts almost 80% of all the oxygen in our blood, and that's the most percentage that any organ extracts to do its job. And then, as I said, when there's increased demand for oxygen, this has to be met by vasodilation, all right? When there's increased demand for oxygen, the heart gets tachycardic, there's less time in diastole, and it's this vasodilation of coronary arteries that allows the blood flow to increase and meet the increased demands. Okay, let's talk about autoregulation. So there are some organs with some tissue beds that are able to maintain a constant blood flow even over a wide range of driving pressures. For example, the brain is very good at autoregulation, and if you look at this slide on the screen here, in the zone where the mean arterial pressure ranges anywhere from 50 to 150, the brain can keep the blood flow constant. The reason it's able to do this is because it modifies the degree of vasoconstriction or vasodilation locally in arterioles that supply blood to the brain. So if the blood pressure goes up, then blood flow will start to increase to the brain. The brain will vasoconstrict arterioles, and that will bring the blood flow back down to keep it normal. And that's why even when the blood pressure gets very high, like over here, the brain can still have this normal amount of blood flow. The opposite happens if the blood flow drops. The brain will sense the decrease in flow. It will vasodilate local arteries in the brain to increase the flow and keep it at normal. Only when your blood pressure gets really low down in this range or really high up in this range does the blood flow to the brain start to change. And the way the brain is able to detect changes in blood flow is by sensing local metabolites. So when there's less blood flow or more blood flow, this changes the amount of carbon dioxide and the pH in the blood. The brain detects that and autoregulates to keep the blood flow constant. So lots of organs besides the brain can autoregulate to keep blood flow constant. So for example, in the heart can detect carbon dioxide, adenosine, and nitric oxide, and the level of these things in the blood tells the heart how much blood flow it has, and then it modifies the degree of vasoconstriction or vasodilation to keep blood flow constant. In the brain, like we just talked about, it uses CO2 and the pH to modify blood flow. The kidneys can detect blood pressure directly by stretch on fibers. It also has mechanisms to detect the amount of sodium chloride being delivered to the macula densa. And I talk about this in the renal modules, but this is the way the kidneys regulate blood flow to keep it constant. The lungs are very sensitive to the amount of oxygen. When there's hypoxia in the lungs, this leads to vasoconstriction so that poorly ventilated areas won't receive a lot of blood. And I talk about this in detail in pulmonary videos. And then skeletal muscle, which I talk about in the video on exercise, skeletal muscle can detect lactate and adenosine and potassium, and it uses these to detect when muscles are being used for exercise and to modify blood flow. And then lastly, the skin is really special. The skin has major innervation by the sympathetic nervous system, and that's the major way blood flow is regulated. So really, like I've shown down at the bottom of the screen here, the skin is very bad at auto-regulating itself. It's largely controlled by the sympathetic nervous system. When the sympathetic nervous system is activated, it decreases blood flow to the skin. When the sympathetic nervous system is inactivated, there's more blood flow to the skin. And this has to do with things like whether the body's under stress or the temperature of the body. The brain senses all these things to modify blood flow to the skin. In contrast, these other organs here, like the heart, brain, and kidney, they're very good at auto-regulating and keeping their blood flow constant. Okay, the last topic for this video is capillary fluid exchange. So you can find capillaries in all the tissue beds in our body, and fluid can either move from the capillaries, outside the capillaries into the so-called interstitial space that surrounds capillaries, or fluid can move in the other direction from the interstitial space into capillaries. And there are two forces that control how much fluid moves from these two spaces and which direction the fluid moves in. So the first force is called hydrostatic pressure, denoted by a P. This refers to the force generated by molecules against walls. So if you look at my little cartoon here, there's a hydrostatic pressure P sub C in the capillary, and there's another hydrostatic pressure P sub I in the interstitial space. If PC is greater than PI, that's going to push fluid out in this direction. On the other hand, if PI is greater than PC, it's going to push fluid in this direction. The second force that controls movement of fluids into and out of capillaries is called the oncotic pressure, denoted by a pi. This refers to solutes, especially albumin, which can draw fluid into or out of capillaries. So just like there's a P sub C and a P sub I for the capillary in the interstitial space, there's a pi sub C and a pi sub I for the oncotic pressure in the two different locations. So let's drill down on this a little further. Hydrostatic pressure, as I said, is fluid pushing against the walls. So in the case of hydrostatic pressure, a high pressure drives fluid toward a low pressure. So if you look over here at our drawing again, if PC is higher than PI, it's going to push fluid in this direction. And the opposite is true if PI is higher than pi C. That's how hydrostatic pressure works. It moves fluid from a high pressure place to a low pressure place. In oncotic pressure, we have solutes like albumin pulling fluid in. So what this means, and this can be a confusing point, is that when there's high oncotic pressure, that draws fluid away from a low pressure location. So once again, let's look at our cartoon. So if pi sub C is higher than pi sub I, that's going to actually pull fluid into the capillary. The opposite is true if pi sub I is greater than pi sub C. So if we know those things that I just explained, we can calculate a net pressure driving fluid into or out of a capillary. It's going to be the difference between PC and PI minus the difference between pi C and pi I. And if you take this net pressure and you multiply it by a constant, which has to do with the permeability of the capillary, you can determine the flow of fluid into or out of the capillary. So I think this will be easier for you to understand if we just make up some numbers and plug them in. So let's imagine that the hydrostatic pressure in the capillary is 100 and the oncotic pressure in the capillary is 50. Let's further imagine that in the interstitial space, the hydrostatic pressure is 50 and the oncotic pressure is 30. This means that the net pressure is going to be 50, the difference between these two numbers here, minus 20, the difference between these two numbers here. And since the net pressure is positive, it's positive 30, this means that fluid's going to move out of the capillary. And if we modified that 30 by a constant for the permeability of the capillary, we could determine the flow of fluid out of the capillary into the interstitial space. So this business of fluid movement into and out of capillaries has clinical relevance when it comes to edema. Edema is what occurs anytime there's excess fluid movement out of capillaries that leads to tissue swelling. So for example, if you have excess fluid movement out of capillaries in the lungs, that's going to lead to pulmonary edema. If you have excess fluid movement out of systemic capillaries, that's what's going to lead to lower extremity edema. That's what's shown in this picture here. When the systemic capillaries leak, that fluid is pulled down to the feet by gravity and patients get swollen ankles. That's lower extremity edema. So for step 1 of your boards, they're going to want you to know what drives fluid out of capillaries in various disease states. So let's talk about that now. So if the hydrostatic pressure in capillaries gets high, that will raise the P sub C and push fluid out into the interstitial space. And that's what happens in heart failure. In heart failure, the left ventricle doesn't work and the pressure in the left atrium gets high, and that makes the P sub C in the capillaries of the lungs very high, and that's what causes pulmonary edema. You can also get edema when there are very low plasma proteins. If P sub C gets very, very low, then we're going to have movement of fluid out of the capillary into the interstitial space. And you can see this in conditions where patients have very low albumin and other proteins in the blood. This happens in nephrotic syndrome and liver failure. You can also get movement of fluid out of capillaries when the capillary permeability, this K sub F factor here, gets very high. That's what happens in infections like in sepsis. Also, certain toxins will do this, and this can happen to tissues that have been damaged by burns. And then finally, if you have very high pi sub I from lymphatic blockage, that can also pull fluid out of capillaries into the interstitial space. In this case, the fluid movement is driven by high interstitial osmotic pressure. Of all these clinical scenarios I've shown you on the screen here, the two that are most high yield to know, in my opinion, are first of all that heart failure leads to high P sub C, high capillary hydrostatic pressure in the capillaries of the lungs, and that causes pulmonary edema. Also, that infections and sepsis can raise the capillary permeability, and that's what leads to fluid leaking out of tissue beds in the setting of sepsis or infection. I'll finish with this one slide and talk about the term third spacing. This is a term you probably won't see on step 1 of your boards, but you'll definitely hear it in the hospitals and clinics. So I want to define it for you now so you know what it means. So third spacing refers to when patients have fluid leaking into places where fluid should not be. And it gets its name because the first space is considered the intracellular fluid. That's about 2/3 of our body fluid. The second space is the extracellular fluid. That's about 1/3 of our body fluid. But then the third space is, as I said, fluid where it should not be. So for example, this patient who has an X-ray on the screen has a large pleural effusion here. There should not be fluid in the pleural space. So we would say that this patient is third spacing. You could say the same thing about a patient who has ascites or cerebral edema. Usually we use the term third spacing to refer to a patient who is leaking fluid from capillaries, and often for a patient who has low intravascular volume but high total volume, because the fluid is not in these two spaces, but instead it's in the third space. And you can see third spacing in patients, especially when they're critically ill, patients who are post-op, patients who have sepsis. And I just want to finish with this slide so you know what this term means when you hear it in the hospitals and clinics. And that concludes our module on regulation of blood pressure.